Let's talk Pulmo.
Welcome to the Deep Dive. Today we're tackling pulmonary embolism, PE for short. Our goal is to really get clear on what it is, how it develops the pathophysiology, and especially how it impacts blood circulation, the sort of hemodynamic effects.
Right, and it's important right from the start to understand that PE and DVT, deep vein thrombosis, are really two sides of the same coin.
Hmm.
We call it venous thromboembolism, or VTE. That link is crucial. And we'll also touch on how PE isn't just one thing. It can range from being completely silent, no symptoms at all, to being a massive, life-threatening emergency.
Okay, so let's start with the basics then. What exactly is PE and what gets the ball rolling?
Fundamentally, PE is a blockage. It's an obstruction in the pulmonary artery, or one of its branches in the lungs. Now, the most common culprit is a thrombus. It's a blood clot. But it's worth noting, sometimes the blockage can be other things, maybe bits of tumor, air bubbles, even fat particles.
So this blockage material, it doesn't start in the lungs, it travels there.
Precisely, that's the embolic part. It originates somewhere else in the body and travels. And the problems it causes are, broadly speaking, hemodynamic, affecting blood flow and pressure, and respiratory, so messing with gas exchange in the lungs.
And you mentioned that strong link between PE and DVT earlier.
Yes, absolutely key. Over 90% of PEs actually start as a DVT, a clot in the deep veins. Usually this is in the legs or maybe the pelvic area. It really highlights why thinking about DVT risks is so vital for preventing PE.
Given how common this sounds, what do we know about the numbers? How often does PE happen?
Well, looking at the epidemiology, the estimates are around 60 to 70 cases per 100,000 people each year. And in terms of impact, it's significant. PE might be responsible for something like 15% of deaths after surgery. Plus, it's a leading cause of maternal mortality in developed countries.
Wow, those are really quite stark figures.
They are. And interestingly, if you look at post-mortem studies, they find evidence of PE in maybe 7 to 9% of cases, people who died from other causes. It's also possible that the numbers we see reported are going up, partly because, well, we're just getting better at diagnosing it now, better imaging, for instance.
Okay, so digging deeper into the biology, what actually causes these clots, these thrombi, to form in the first place?
Well, the classic explanation for thrombus formation is something called Virchow's triad. It's basically a framework describing three main categories of factors that predispose someone to developing a clot. Think of it as the perfect storm conditions for clotting.
Right, the triad. What are the three parts?
Okay, first is endothelial injury. This means damage to the inside lining of the blood vessel. Things like trauma, surgery, inflammation, even having a central venous catheter in place can cause this kind of injury. The body's clotting system can get triggered by that damage.
Okay, that makes sense. A damaged pipe wall triggers a repair, which involves clotting. What's the second factor?
Second is stasis of blood flow, or venous stasis. Basically, blood flow slows down or stagnates. Think about prolonged immobility, like after surgery or on a long flight, or conditions like congestive heart failure or obesity. When blood isn't moving well, clotting factors can kind of hang around longer and are more likely to initiate a clot.
And the third element of this triad?
The third is hypercoagulability. Essentially, the blood itself has an increased tendency to clot. This can be inherited things like factor V Leiden, prothrombin gene mutations, or deficiencies in natural anticoagulants like protein C, protein S, or antithrombin. Or can be acquired. Think malignancy, pregnancy, taking oral contraceptives or hormone replacement therapy, certain kidney diseases like nephrotic syndrome, antiphospholipid syndrome, and even infections like COVID-19 have been linked to this. The blood is just stickier, more prone to clotting.
So it's often a combination of these things, vessel damage, slow flow, and sticky blood that sets the stage. What are these clots actually made of?
Good question. A typical thrombus is a mix of platelets, fibrin, which is like the meshwork of the clot, red blood cells, and some white blood cells trapped in there too. And where do they usually form? Well, overwhelmingly in the deep veins. About 75% start in the lower legs or the pelvis. Those Virchow's triad factors often come together in those areas.
Okay, so the clot forms, often in the leg. How does it then become a pulmonary embolism?
Right, that's the embolization phase. The thrombus, or a piece of it, dislodges, breaks free. It's estimated that maybe 20% or so of leg thrombi actually embolize. So it's important to remember not every DVT automatically causes a PE.
Still, that's a significant number. So this clot breaks free and travels. Where does it go?
It travels up to the venous system, gets pumped through the right side of the heart, the right atrium, then the right ventricle, and then it's pushed into the pulmonary artery. It keeps traveling until it gets stuck in one of the pulmonary artery branches. How much blockage it causes really depends on the size of the embolus and exactly where it lodges. A really large one might get stuck right where the main pulmonary artery splits in two. That's called a saddle embolus.
And when that blockage happens in the pulmonary arteries, what are the immediate effects on the lungs and the rest of the body?
It sets off a cascade. First, obviously, there's the physical blockage, the mechanical obstruction to blood flow. But it's not just that. The body reacts. There's neurohumeral vasoconstriction. The blood vessels in the lungs actually constrict, clamp down, partly due to substances released like serotonin, thromboxane A2, and endothelin-1. So you have the blockage plus constriction, and both dramatically increase primary vascular resistance, PVR. Think of PVR as how hard the heart has to push to get blood through the lungs. It goes way up.
So, much higher resistance for blood flowing through the lungs. How does that affect breathing and oxygen levels?
Well, that increased resistance directly leads to impaired gas exchange.
Yeah.
The main issue is what we call ventilation perfusion mismatch, or VQ mismatch. Basically, you have part of the lung getting air, ventilation, but little or no blood flow, perfusion, because of the blockage. This creates alveolar dead space. Air comes in, but can't participate in gas exchange. This VQ mismatch is a major reason for hypoxemia, low oxygen in the blood. Other things can contribute too, like if the pressure on the right side of the heart gets high enough, blood might shunt through a patent Foreman oval, bypassing the lungs. And sometimes oxygen diffusion itself might be slightly impaired.
And I gather this can sometimes lead to actual damage to the lung tissue itself?
Yes, that's right. In about 10 to 15% of PE cases, you can get pulmonary infarction, essentially, death of lung tissue. This seems more common with smaller clots lodging further out in the periphery of the lung, especially if the person already has underlying heart or lung problems. Infarction often causes that sharp chest pain that gets worse with breathing pleuritic pain and sometimes coughing up blood, which we call hemoptysis. And of course, the clot itself triggers inflammation, releasing cytokines and activating immune cells like neutrophils and platelets.
Does the body try to deal with the clot itself?
It does. There's a natural process called fibrinolysis, where the body tries to dissolve and break down the thrombus. But sometimes this process isn't complete or doesn't happen fast enough, and if the clot doesn't resolve properly, it can lead to a serious long-term problem called chronic thromboembolic pulmonary hypertension, or CTEP, basically persistent high blood pressure in the pulmonary arteries.
We've talked a lot about the lungs. Let's shift focus now more to the heart and the circulation, the hemodynamic consequences you mentioned earlier. How does PE affect them?
Okay. The absolute primary hemodynamic effect of a PE is a sudden increase in the workload of the right ventricle. We call this increased right ventricular afterload. As we said, this comes directly from that increased PVR, the resistance caused by the blockage and the vasoconstriction. It's interesting, though, in someone with previously healthy lungs, the mean pulmonary artery pressure, the average pressure often doesn't rise dramatically until about 30 to 50% of the pulmonary vascular bed is actually blocked.
So the right side of the heart is suddenly forced to pump against much higher resistance. What does that do to the heart muscle itself?
It puts immense strain on the right ventricle. This leads to RV strain, and if it's severe enough, RV dysfunction. The RV chamber can dilate, stretch out, and the wall tension goes up significantly. This can even compromise the RV's own blood supply, potentially causing RV ischemia like a heart attack at the right ventricle. Also, as the RV struggles and pressure builds, the wall between the ventricles, the interventricular septum, can bulge over into the left ventricle. This physically squashes the left ventricle, making it harder for the LV to fill with blood during its relaxation phase, diastole. On an echo, you might see this as a D-shaped left ventricle. If that means pulmonary artery pressure acutely jumps above, say, 40 millimeters of mercury, the right ventricle is really at high risk of failing.
And if the right ventricle does start to fail, what's the knock-on effect for the rest of the body's circulation?
Well, if the RV can't effectively pump blood through the lungs, then less blood gets back to the left side of the heart. This means reduced left ventricular preload, less blood filling the LV before it pumps. Consequently, the cardiac output, the amount of blood the heart pumps out, each minute drops. And when cardiac output falls, systemic blood pressure goes down. In severe cases, what we call high-risk or massive PE, this can spiral into systemic hypotension and obstructive shock. That's a life-threatening state where the body's organs aren't getting enough oxygen because the circulation is failing due to the obstruction.
Are there other body systems kicking in that worsen things?
Yes, there's also significant neurohumoral activation. The sympathetic nervous system, the fight-or-flight system, gets activated, and more vasoconstricting substances like endothelin-1 and thromboxane A2 are released, which can actually worsen the pulmonary vasoconstriction and increase the PVR even further. It can become a vicious cycle.
And this drop in overall circulation also worsens the oxygen problem, even beyond the VQ mismatch in the lungs.
Exactly. The low blood oxygen, the arterial hypoxemia, isn't just about the lungs. The fall in cardiac output is a big contributor too. When less blood is circulating, the blood returning to the heart from the body is more deoxygenated. Its mixed venous oxygen saturation, or SVO2, is lower. So even the parts of the lung that are getting blood flow might not be able to fully reoxygenate this poorer blood, especially when the overall flow is reduced.
It's really clear just how complex PE is, with effects spreading far beyond the initial clot in the lung.
Absolutely. It's a fascinating and dangerous interplay. It starts with clot formation, leads to this blockage in the pulmonary circulation, and spirals into major problems with breathing and blood flow, potentially very quickly.
So just to recap what we've covered today. We define pulmonary embolism as that blockage, usually from a DVT. We discussed its frequency and impact. We explored Virchow's triad vessel injury, blood stasis, hypercoagulability as the basis for clot formation and how these clots embolize to the lungs. Then we looked at the consequences: impaired gas exchange, potential lung tissue death, infarction, and critically, the hemodynamic affects the strain on the right heart, leading potentially to RV failure and shock. It's quite a cascade.
It really is. And what strikes me is how a single event, that embolus lodging in a pulmonary vessel, triggers such a widespread physiological storm, affecting both breathing and circulation so profoundly. It really makes you think, doesn't it? How does the body try to compensate for all this? And perhaps more critically, what are the tipping points where those compensations just get overwhelmed, leading to those really severe, life-threatening outcomes? Something to ponder.